workload that we have today. Thank you, Monica, for asking me to do the presentation one more time.
Thank you.
Most of you in this room have heard me do this talk several times before, so this is going to be a gentle refresher for what we're going to be doing in this facility if we had an MH crisis. MH, we've got Craig here. You probably don't know what the term means. It means malignant hyperthermia. And malignant hyperthermia is a genetic disorder that, when I started in the business in 1970, if it occurred, was 80% fatal. 80% fatal. It was like the boogeyman of all of the bad things that could happen that were just out there in the periphery, waiting to spring and ruin everybody's day. Today, the mortality rate of a full-blown MH crisis is right around 10%. 1 out of 10 ain't bad, but still, for the 10% that have a full-blown MH crisis, a devastating insult, a devastating injury. There are some specific things about this facility that we've got to be aware of. You can sit up front, just like church. That we've got to be aware of. And most of the old-time employees know very well, because I've beat it into their heads for several times already. But for new employees, Mr. Reynolds,
Yes, sir. I'm here for you.
we're going to reinforce some of the things that are specific about dealing with this life-threatening emergency in our institution. Now, I've got a video. It's the same video that I played before, but on my research on other videos from M-House, I still think that for this audience, this is the best device, or the best video that is appropriate for our audience. So, let's see if we can get the light to come back on.
Good morning.
There we go.
Shall I dim the lights?
Yeah.
Thank you.
Malignant hyperthermia, MH, is a syndrome affecting skeletal muscle in which triggering agents such as inhaled anesthetics and succinylcholine initiate a complex series of biochemical changes that result in hypermetabolism, acidosis, and electrolyte imbalance.
On the right.
Sustained muscle contraction is often a hallmark of MH. Skeletal muscle is comprised of a series of tubular structures, filaments, and other organelles that regulate muscle metabolism and contraction relaxation. Two filaments, actin and myosin, slide over each other to produce muscle contraction. Calcium, which is stored primarily in the sarcoplasmic reticulum and to a lesser extent in the mitochondria, regulates the beginning and end of muscle contraction in response to a neural stimulus. Once the stimulus for contraction is gone, calcium is taken back up into organelles and the muscle relaxes. The MH trait is thought to alter the way in which a muscle releases and stores calcium. This metabolic error becomes clinically significant after exposure to the triggering agents. The inhalation inhalation anesthetics, halothane, enflurane, isoflurane, and desflurane, are all known to trigger MH. Other inhalation agents, except nitrous oxide, are implicated by association. The muscle relaxant succinylcholine is also a triggering agent. Agents that do not trigger MH include local anesthetics, nitrous oxide, benzodiazepines, non-depolarizing muscle relaxants, propofol, barbiturates, and ketamine. Once the process has begun in skeletal muscle, there are several consequences. Carbon dioxide production increases, making it difficult for the anesthesiologist to supply sufficient ventilation to the patient. At the same time, hypermetabolism causes a rise in body temperature and the development of metabolic acidosis. Sustained contraction also interferes with cell membrane function. An outpouring of potassium from the cell occurs, and high levels of extracellular potassium are not uncommon. These high extracellular levels of potassium are likely to affect heart rhythm and require immediate treatment. This total derangement of physiologic function can cause serious end organ damage. Myoglobin, released from damaged muscle, moves into the bloodstream. When myoglobin arrives at the kidney, it is filtered and may lead to renal failure. If MH is left untreated, death usually ensues. Dantrolene sodium is a fast-acting, effective treatment for MH, which has been in use since the 1970s. It relaxes muscle by a different mechanism than other muscle relaxants used in anesthesiology. Given intravenously, at appropriate doses and in combination with other emergency treatment, it speedily and effectively arrests MH with few side effects. Malignant hyperthermia has been identified in almost every country of the world. It may occur in infants and the elderly, but it most often occurs in older children and young adults. MH is an inherited disorder and occurs in both sexes. Its mode of inheritance is autosomal dominant. Investigators suggest that certain physical characteristics like extraocular muscle abnormalities or spinal deformities may occur more frequently in MH-susceptible patients. These suggestions have yet to be confirmed by rigorous scientific studies. Duchenne muscular dystrophy seems to be associated with MH susceptibility, as are a few other muscle diseases. Not so long ago, mortality associated with MH was about 80%. The introduction of dantrolene and intensive education programs have brought the mortality rate to under 10%. The incidence of MH in the general population is unknown. During general anesthesia, the incidence is reported to be as high as 1 in 10,000 to as low as 1 in 200,000. Presenting signs of MH include trismus after succinylcholine, marked increase in heart rate, abnormal ventricular heartbeats, and total body rigidity. Trismus does not always equate with MH. However, trismus should raise a red flag, since 20% of patients who experience trismus will develop clinical MH. Most often, the anesthesiologist will first notice unexplained sinus tachycardia and elevated carbon dioxide levels in the expired gas. In fact, an unexplained increase in exhaled carbon dioxide is the earliest, most sensitive sign of MH. Key to managing MH is prompt, early recognition, stopping the triggering anesthetics, hyperventilating the patient with 100% oxygen at 2 to 4 times normal minute ventilation, and simultaneously beginning treatment with dantrolene. Securing appropriate lab studies and maintaining the patient's vital physiologic functions are also important. Close, well-rehearsed, and coordinated teamwork of the entire operating room staff is essential. An appropriately equipped MH emergency cart is also essential. It should contain enough dantrolene to treat a 70-kilogram patient, 36 vials, and 2 liters of sterile distilled water. In addition, the cart should contain bicarbonate, glucose, and insulin to treat metabolic disturbances, 50 milliliter syringes with which to mix the dantrolene, nasogastric tube, Foley catheters, urimeter, large plastic bags for ice with which to cool the patient, and saline and glucose solutions. Laboratory equipment should include specimen containers for serial CK or CPK determinations and electrolytes, blood gases, coagulation profiles, PT and PTT, and urine specimens. An MH cart like the one we have just described might be a luxury item for some institutions. Most of the essential items can be easily stored in something as basic as a large tool or tackle box. To keep confusion at a minimum once the MH crisis begins, everyone involved must know exactly his or her role. The anesthesiologist announces an impending MH crisis and takes charge. Other members of the team should respond to the anesthesiologist's direction. One person is designated as timekeeper recorder. The timekeeper notifies the OR that there is an MH crisis, mobilizes extra help as needed, and coordinates lab services. The surgeon closes the incision as quickly as possible and should then remain as part of the treatment team. The surgical tech and circulating nurse might assist the surgeon with closure, help with preparation of dantrolene, gather ice for cooling, or transport specimens to the lab. Tom is a robust young man scheduled for an inguinal hernia repair. His history and physical are unremarkable. He had surgery once before to set a fractured wrist under regional anesthesia. His operation is planned as a one-day surgical procedure.
That repair shouldn't be too difficult.
Yeah, it seems like it should be fairly straightforward. Everything okay?
Well, his jaw seemed a little stiff during the laryngoscopy, but sometimes after succinyl choline, that's normal. Everything seems fine now. What's going on here? Something's not right. He's so tachycardic. Is he too light? Why is he overbreathing the ventilator? I'm giving him more than enough ventilation. I wonder if this CO2 canister is expired. It's turning blue. Wait a minute. Dave, I think we have a real problem here. I think we have a case of malignant hyperthermia. I need you to close as quick as you can. Donna, get ready to draw blood gas. Debbie, go get the MH kit now.
Okay, Roger, go get some ice and put some trays of saline to fill ice too.
The anesthesia is switched off. The oxygen flow is increased to 10 liters per minute, and the patient is hyperventilated. Temperature may rise quickly during an MH crisis to as high as 110 degrees. Place an oropharyngeal or axillary temperature probe, and then, if a cooling blanket is not available, pack the patient in ice, starting with the axilla and groin first. This will help cool the patient. Each vial of dantrolene contains 20 milligrams of drug to be mixed with 60 cc's of sterile distilled water. Dantrolene does not mix easily, so some suggest having 2 or more people mix the vials. Dantrolene, 2.5 milligram per kilogram of body weight, is the recommended starting dose and may go to a maximum of
Is isn't technology grand?
Oh, yeah.
In a word.
Tape broke. The tape